Okay, well, I cannot live up to that, so maybe I shouldn't give this lecture. But anyhow, we're going to talk about peripheral arterial disease. Just a few disclosures. So as you know from attending this conference, atherosclerosis is a systemic disease. And the thing is, it has different names, right? So if it happens in your legs, we call it peripheral arterial disease. If it happens in your heart, we call it coronary artery disease. If it's in your brain or in your vessels going to your brain, we call it cerebrovascular disease. But it's all the same disease. And so folks that are at risk for one of these are at risk for the others. And in fact, if you look at PAD patients, for example, about 63% of them have disease in other vascular territories, coronary or cerebrovascular. So when you see someone with a history of a stroke in the past or a history of an MI, you should assume that they likely have peripheral arterial disease. And likewise, if they have PAD and they haven't yet had a stroke or MI, they likely are at high risk for that. So you should consider that. Why do we care about PAD? Who cares? Well, you can plot it on one graph to show why it matters. So obviously, if you look at survival over years, even normal subjects die. So we do have a mortality. But if you have PAD but don't even know it, you have no symptoms, your outcome is worse than someone who doesn't have it. And the more symptomatic you are, the worse your outcome. So this is why we should care about it. So who's at risk? Sadly, a lot of us. And this is from the most recent AHA-ACC guidelines, which came out last year. Essentially anybody over the age of 65, which is a lot of people, obviously. Anyone between the ages of 50 and 64 that have risk factors for atherosclerosis, like diabetes, smoking, dyslipidemia, hypertension, or a family history. Anyone less than 50 that has diabetes, as well as one additional risk factor, like, say, smoking. And anybody that already has, again, like I said last time, has existing evidence of disease in other vascular territories are obviously at risk of having PAD. Now, this is the sobering reality about PAD. It's a bad disease to have. And the reality is that, there's various risk scores, but this one is actually kind of scary. So if you have patients that refuse to take medical therapy and they have PAD, you can calculate out their risk score and give them an idea of what their mortality is going to be if they don't take appropriate therapy. And you can see that the highest risk patients have about a 70% 10-year mortality, which is obviously not very good. Patients with symptomatic PAD, on average, have about a 4 to 5% chance of a heart attack or stroke per year, and about 1 to 2% risk of an adverse limb event, i.e. gangrene, amputation, or needing an intervention of their limb per year. And ultimately, about 60% of patients with PAD will die from an MI, and about 12% will die from complications from a stroke. So this is obviously a very, very bad disease, and we should take it very seriously. And if you do have PAD and you happen to come in with your cardiac event, you will do worse than someone that doesn't have PAD. So this has been well studied now, that folks that have coexisting PAD and coronary disease and suffer an MI or cardiogenic shock have a much higher rate of amputation, lower extremity revascularization, bleeding issues, readmission to the hospital, heart failure, etc. So it's just a marker of badness, if you will. But sadly, PAD is still everywhere. As long as people continue to make poor choices like smoking and poor dietary choices, it will still be with us, and I think it's somewhat on the rise. So here's the thing. A lot of people say, well, when I see folks in clinic, I ask them if they have claudication symptoms, and that's a good enough screening test for PAD. The reality is it's not. Because if you look at all folks with peripheral vascular disease, only about 60% of them are going to complain of some sort of symptoms, and of those, only about 10% will actually have the classic claudication, which is heaviness, exercise-related fatigue that goes away when they stop. Only about 10% of all PAD patients. And about 40% will be entirely asymptomatic, but again, at worse prognosis, so there's opportunity for intervention with medicines and diet and lifestyle changes that you wouldn't pick up by simply asking about symptoms. History is very important with this disease. So I know in this day and age, we have such short period of time with our patients in clinic, and it can be very challenging to get a good history, but it's really important. And what I can tell you, a couple pearls, is that people that have symptomatic PAD, especially older folks, all of us as humans like to avoid things that are painful. So when it's painful to walk or exercise, we subconsciously reduce the amount of activity we do to avoid being uncomfortable. And so many folks will come in and they'll say, well, I don't have any symptoms. And we'll say, well, tell me about how active you are. Do you do anything? No. How come? Well, if I do anything, my legs hurt. There's your answer. But you have to take that history. They won't volunteer it in many cases. And also, if they come in with a family member or loved one, ask that person, because they will oftentimes sort of rat out the other individual. They'll say, well, Joe, that's not true. You stopped playing golf last year because you said your legs hurt. You're like, oh yeah, I forgot about that. So, asking family members and loved ones can be very helpful in the history as well. And a lot of times, especially older folks, feel that these symptoms they're having are just part of the natural aging process of getting older, and simply not true. So the next step, of course, is a physical exam, and not to show you too many gross pictures, but in full disclosure, there'll be some gross pictures later on. This is some important things about physical exam. Of course, we want to check the pulses. So we want to check them in the femoral location, the popliteal location, and in the pedal locations. We want to listen for bruits over the stomach, typically there for triple A's or renal artery stenosis. Look for any evidence of wounds on the feet or any changes associated with that we typically see with PAD, like dependent rubor. What the heck is that? Well, the picture on the far left is dependent rubor. So when you lift the leg, like on the far left side of your screen, the foot becomes pale. When you put the foot down, it becomes bright red. And the reason that's happening is the microcirculation is maximally dilated, trying to get blood flow. And so when it's maximally dilated, you get this sort of red look. And then when you raise the limb, of course, gravity is not helping the situation, and the limb is pale. So you want to look for those kind of things. And then obviously when there's dry gangrene like the person in the middle has, it's pretty obvious, but we'd like to not get to that point if possible. And then other things that are suggestive of PAD. For example, always check the blood pressure in both arms, unless they have a fistula or some reason not to. If you see a discrepancy, they automatically have PAD by definition. So you can't get a discrepancy unless you have something going on, unless you have a coarctation or something. But in general terms, they're going to have PAD. So it's important to look for some basic things like that. This is a busy slide, but these are how this is the full physical exam. And when you measure pulses, 0 is absent, 1 is diminished, 2 is normal, and 3 is bounding. Bounding is not necessarily good. That implies an aneurysm. Take the socks off. I know it's difficult. We have a short time with the patient, but you would be surprised at some of the things I've found over the years that patients do not volunteer. So you say, well, do you have any wounds or sores on your toes? Nope. When you take the socks off and you look under their foot and you say, what about that? Oh, that's been there for 5 years. Yeah, it doesn't bother me. Yeah, it's a problem though. So always take off the socks. It's very important. And again, history is important because if someone has leg discomfort, it's not always PAD. And here's a really important pearl I can share with you. Because we already said that anyone over 65 is at risk of PAD, statistically speaking, someone over the age of 65 may very well have an abnormal pulse exam or may have evidence of PAD on ultrasound, but they may not have symptoms from it. So a common thing that happens in many cases is no one takes a good history, they just do an ultrasound, and they say, oh, the ultrasound's abnormal, oh, we have to do something about your vascular disease, like put in a stent or something, and that's not true. Because many of those patients are actually asymptomatic and they need medicine, they need exercise, they need lifestyle changes, and not intervention. So just because PAD is found doesn't mean it's the culprit for their symptoms. And many times if you take a history, you'll find out, this is more like a spinal problem. They're having nerve root impingement. But if you don't take the time to get that history, you can see how patients can get unnecessary treatments. So it's really, really important to realize that. So patients with PAD in clinical practice will present to you in one of 4 ways. Either truly asymptomatic, but again, many of them have a functional impairment. If you're not exercising, are you really asymptomatic? So you have to ascertain that. Then there's the classic claudican, as we mentioned, but only about 10% of folks with PAD really have that, which is the muscular discomfort and heaviness that occurs with exercise. It's very reproducible and goes away with rest. Then you have the patients that are really in bad shape. This used to be called critical limb ischemia. Now it's called chronic limb-threatening ischemia, or CLTI. These are folks that have so little blood flow to their limb, they can't maintain the status quo of their tissues. So they're getting issues with ischemic rest pain. They're getting issues with non-healing wounds or gangrene. These people are in very serious jeopardy of losing their limb and potentially their life. And then you have the final category, which is acute limb ischemia. Many of you may remember this from training, the so-called 5 Ps that you don't want to miss. Sudden onset of pain, pulselessness, pallor, paresthesias, or paralysis is a sign of acute limb ischemia. And this typically happens when someone either has, for example, atrial fibrillation and embolizes a clot to their common femoral artery, for example, or has a plaque rupture in their iliac artery and their leg becomes acutely ischemic. Similar to the heart, when there are very minimal collaterals there, and there's no time for collaterals, it's like having an MI. This is an emergency you don't want to miss. So, someone like this comes in with the 5 Ps. Now, this person has obvious evidence of chronic limb ischemia with ulceration. But if this is missed, that this is acute, it turns into this, and then it was a non-salvageable situation. So again, this is a busy slide, but if you were asleep the entire time from what I was just telling you, you don't have to remember anything except for the following. Any of those 4 patient criterias, the next step is do an ankle brachial index. And that's typically done for patients to look for evidence of PAD if they're at high risk. So what is an ankle brachial index? Well, it's a simple thing, simple concept, which is this. If your arteries are wide open and there's no blockage, your blood pressure in your arm should basically be the same as it is in your ankle. If you have obstruction in your leg, the pressure in your ankle is going to be lower than the pressure in your arm. And the lower that is, the worse off you are. And simply calculating that ratio by using blood pressure cuffs and Dopplers is what an ABI is. It's very, very simple. So this cannot be done with an automatic blood pressure machine. You need to do a manual cuff with a Doppler, or there are some machines that will do this for you, but they are specialized for this. And basically a normal range is somewhere between about 1 to 1.3. Borderline is about 0.9 to 1, mild impairment is 0.7 to 0.9, moderate is 0.4 to 0.7, and severe is less than 0.4. Interestingly enough, if your ABI is greater than 1.3, it's also very bad. Because if you realize how the test is done, you have to fully compress the artery and then release the pressure to get a signal. Well, if your artery has medial calcinosis, you can't compress it, so your ABI is artificially higher, and that's also a marker of badness. So it's not good to have an excessively high ABI. You can actually take that one value, the ABI that you did on your patient, and calculate it based on mortality, just that one number. And so if you're in the normal range, you have the lowest mortality. And the lower your ABI, the worse off you are. And of course, if you're in the upper range of the non-compressible, we call it, where there's medial calcinosis, you also have a worse outcome. Now, how does this compare to other screening tests? We do a lot of screening tests in medicine, right? Pap smears, fecal occult blood tests, mammograms. The ABI is an incredibly powerful test. It's about 95% sensitive and 100% specific for the presence of peripheral arterial disease, versus a lot of the other stuff that we do routinely is not so good. So what do the guidelines say? Basically, for ABI testing, it's recommended to do this for patients that have a history or physical examination findings concerning for PAD to establish the diagnosis, okay? But routinely doing this on someone that's not at risk, has no symptoms and no physical exam, signs or symptoms of PAD is not recommended, okay? So that's the important point there. What if the ABI is normal, the resting ABI? Does that mean that PAD is not a possibility? No. Okay, so interestingly enough, you can have proximal obstruction. So this is a CTA of one of my patients, and you can see that their external iliacs, where I've pointed with the arrows, are 100% occluded, but their resting ABI is 1, completely normal. Why is that? Well, when you're not exercising and your muscles are not being used, all of the microcirculation is constricted down. And if you have collateralization like this gentleman does, there's enough flow at baseline to have a normal ABI. But the moment you start walking or using your calf muscles, all of the muscles, all the microcirculation opens in the muscles, and that pressure drops, and the ABI drops because supply cannot keep up with demand. These are the people that you would consider doing exercise treadmill testing on. So if you're really convinced their symptoms sound great, the story sounds great, they're at risk, but the resting ABI is normal, just to be sure, you can send this person for a treadmill ABI, and they will find that the ABI drops with exercise. Some labs, like ours, won't even do the treadmill. They'll just do calf raises like this, and after about 10 calf raises, the ABI drops way down, and you made the diagnosis. So that's recommended in the guidelines. What about diagnostic testing? So a lot of people say, when do I do imaging? Well, the reality is that there's no reason to do any additional imaging like CT or MRI unless the patient falls into a category of advanced enough disease that they need to be revascularized, and we need to know what their anatomy is to figure out a suitable revascularization plan. So if they're asymptomatic, you don't need to do a CT or MRI. It's not helpful. In fact, in the guidelines, it's class 3. It's for harm. So the time that we would do this is for someone that's symptomatic and is being thought about for revascularization. That's when we would do advanced imaging. Otherwise, there's no indication to do so. All right, so you've made your diagnosis, your patient has PAD, what do you do about it? Well, the first thing is to figure out what their symptom status is. If they're asymptomatic, treat them as if they have coronary disease, because likely they do, like we talked about. And then, of course, observe them over time for any clinical changes that might become important, like development of ischemic symptoms in their feet or wounds or claudication. If they already have claudication, the first thing you want to do is you want to get them on medical therapy and encourage them to attend a supervised exercise program. Because supervised exercise programs have been shown to improve quality of life and walking distance for these patients. Now, if they are severely limited, so they have very proximal disease, like their abdominal aorta is occluded or their common iliacs are occluded, they will not be able to exercise adequately to perform, to participate in one of these studies because they can't walk more than 10 feet, and those patients just need to be revascularized. But for the majority of patients, exercise therapy is the first strategy to go for. And of course, if you give them medical therapy, you get them to quit smoking, you get their diabetes under control, and they've done exercise and it's still not adequate and they're still limited, you would consider revascularization. Because if you don't, remember, human nature is to avoid discomfort. They will become couch potatoes, they will get fatter, their diabetes will get worse, and it's a downward spiral. If they already have ischemic rest pain or gangrene or wounds, they need to be revascularized. You don't want to sit on that. So what about medical therapy? What is appropriate medical therapy? Well, if your patient is asymptomatic, again, treat them as if they have CAD. So statins or PCSK9 with the goal of LDL less than 70 is really what's recommended. ACE inhibitors for hypertension and, of course, diabetes control. We also want to teach them how to self-examine their feet to look for any evidence of changes or wounds. Wearing proper shoes and not walking around barefoot on a hot summer day is probably ideal. Encourage them, especially if they're diabetic, to see podiatrists and get proper nail care and proper foot care. And we start these patients on single antiplatelet therapy, typically aspirin 81, or looking at the Capri trial, there's some data that isolated clopidogrel 75 milligrams a day is reasonable. What about symptomatic PAD? Well, you'd follow all the same stuff I just said, but on top of that, you'd look at kind of the situation. If they have not had recent revascularization, they're definitely going to be on single antiplatelet therapy, or you can consider putting them on aspirin and rivaroxaban as part of the COMPASS trial, which we'll talk about. If they've had recent revascularization, we typically don't follow that strategy, and they're usually on dual antiplatelet therapy for preservation of patency of their stent or their bypass or whatever they've had done. So the evidence for statins and PAD is very clear. There's a substantial benefit to folks getting treated with high-intensity statin therapy that have PAD, and this improves outcomes. So this is a study from some years ago, but clearly patients that got high-intensity statin therapy had improved survival, fewer major adverse cardiac events compared to patients on low-intensity statin therapy or no statin therapy. The COMPASS trial was another study looking at platelet and antithrombotic medication potentially to reduce bad outcomes in PAD. So basically this was a trial that had 3 arms of patients. These were primarily symptomatic lower extremity peripheral vascular disease patients. One group got rivaroxaban 2.5 milligrams twice a day with aspirin. One group just got rivaroxaban 5 milligrams twice a day, and one group just got aspirin daily. And if you look here, the patients that were excluded are often criticized in this study because this is a lot of our patients. Anyone that had a recent stroke, has any history of bleeding, had any severe heart failure, ejection fraction less than 30, or a GFR less than 15 were excluded because obviously with rivaroxaban we can't give it to you if you have renal dysfunction. So what did it show? Well, basically it showed that the primary outcome, which was cardiovascular death, MI, or stroke, occurred in 5% of patients who got the low-dose rivaroxaban plus aspirin, and it happened in 7% of patients who just got aspirin, so a 2% difference. Low-dose rivaroxaban plus aspirin was superior to aspirin alone, but in contrast, the primary outcome in the rivaroxaban alone group was not good because of bleeding issues. So obviously bleeding is the main downside of this. It goes without saying, if your patient is diabetic, get their diabetes under control the best you can. This is a study just purely looking at the A1C and plotting that relative to looking at the probability of that patient being admitted for a PAD-related complication. The higher the A1C, the more likely the patient is to get admitted for some sort of limb-related problem like gangrene, infection, etc. So again, exercise therapy is strongly recommended by the guidelines. It needs to be supervised because, as we all know, if you tell someone go home and quit smoking or go home and exercise, patients just don't do it. So they need to go to a structured program where they have sort of a drill sergeant keeping, kind of pushing them because it starts to hurt and they need to push through the pain, and they sort of need a motivational individual to help them with that. So supervised exercise is much more effective than just telling someone to go home and exercise. This has been shown to improve quality of life, walking distance, and functional status in claudication patients. What about cilostazol? So this is a therapy that can be very useful for patients with claudication. It has been shown to improve walking distance and reduce symptoms in some patients. Not all patients respond to it. Importantly, it is contraindicated in anyone that has any history of heart failure of any kind because it can exacerbate the heart failure, okay? Also, it is for claudication only. It is not a substitute for revascularization for people that have critical limb ischemia or chronic limb-threatening ischemia. So if you have gangrene, cilostazol is not an appropriate therapy. So who gets revascularized? it's going to be either patients with lifestyle-limiting claudication that have failed conservative measures. They've stopped smoking, their diabetes is controlled, they've tried exercise, they're taking all their meds, and they're still very impaired and cannot, appropriately participate in activities that they enjoy. That type of person should be revascularized. And of course, as we discussed, anyone with limb-threatening ischemia should be revascularized. So what are the options for revascularization? Well, surgery, bypass surgery has been around the longest. Obviously, it works, but it is very invasive. And there's important things to realize. In order to do a good bypass, you need to have a good conduit. What does that mean? That means you need to have a saphenous vein as a spare part. That's good quality. And you need to have a good target. You need to have some place to sew that to that has adequate runoff and of good enough quality for it to work. So if you don't have a good conduit and you don't have a good target, you can't do a good quality bypass. But it is high-risk surgery. Based on reports, the major adverse cardiac event rate is roughly about 5% or even more in some reports for some of these patients. Because again, these are high-risk patients by definition, so they're at high risk of heart attack and stroke. And the number one complication from bypass is usually an MI or some sort of cardiac event. What about patency of these bypass? Well, there was a large meta-analysis done some years ago. And basically, if you do an above-the-knee saphenous vein graft bypass, it's about a 70% patency rate at 5 years. But if you use synthetic conduits or you go below the knee, that patency rate drops dramatically. And here's the problem. Here's an example of a patient that I took care of some years ago. It was only 2 weeks after having a FEMPOP bypass, and they came in with an ischemic leg. It was completely pulseless. And you can see it was thrombosed. The graft was thrombosed. So I sucked all the clot out and cleaned it up. And I took a picture, and I did a CTA, and I said, why did this graft fail? And you can see exactly why the graft failed. You have this large graft going to tiny thready vessels that are essentially subtotally occluded. So the targets, the runoff is poor. And so just like a 5-lane freeway, if the construction crew narrows it down to 1 lane, all the cars back up to try to get into that 1 lane. And so when blood backs up, it clots. And so this is a type of situation where bypass fails. So endovascular therapy has really become the most common revascularization therapy because obviously it's lower risk, but also you can address the outflow. Versus with bypass, you can't. You have to find an outflow to go to, and if there isn't one, you can't do one. So with endovascular therapy, patients are at lower risk for this type of procedure because it's pretty low risk, and you can address the outflow. So we do this with conscious sedation. It's just done percutaneously, just like any type of catheterization procedure. And we have data now with newer devices and technologies that's really changed the game. So this is data for drug-eluting stents that are now used in the superficial femoral artery and the popliteal artery, and at 4.5 years, the patency is 83%. As I told you before, for saphenous vein grafts, it's about the same. So we can get similar results without doing an invasive bypass. So, a lot of people say, well, what do I do, surgery or endovascular? It all depends on the patient and their specific details, which is far more than I can go into in this talk. But basically, it's lower risk, which is why it's become so popular. And many of these folks are very elderly and very sick, and they don't do well with general anesthesia and with large operations. And also, the downside is it can be very technically challenging, particularly when someone has chronic limb-threatening ischemia, because you're never going to have a simple lesion and have gangrene of your foot. It's always going to be very complex. Long segment occlusions, multi-level disease is very common, calcium is very common, and these are all challenges for doing endovascular procedures, because with a bypass, you can just go downstream of all that stuff, but for endovascular work, you have to take it on and go through it. So that can make it challenging. So this is a typical angiogram of someone that would have chronic limb-threatening ischemia. So these are the 2 legs. You can kind of see the knee joints down there, and you can see there's lots of collaterals, but all the areas I've marked are where they're totally occluded segments. So we have to get those open in order to get inline flow to the foot or to the wound to get it to heal, and that can be very challenging. So we've come up with all kinds of ways of doing this, but clearly the technique that's really helped a lot is what we call combined antegrade and retrograde technique, meaning we go in from above like standard, but we also go directly in from the foot with a tiny needle and a tiny wire and go backwards and kind of meet in the middle. And this has really improved the success rate of these complex procedures. So here's what it looks like. This is called pedal access. You may have heard of it. But basically, this is just me sticking a tiny wire and a catheter into someone's posterior tibial artery. And this is very similar to doing radial, right? So many of you know in cardiology, we don't go through the femoral routinely anymore. We typically go radial because the artery is small, but it's superficial, and it's right over a bone, and it's easy to compress. Same is true here. You can put one finger on this, take the catheter out, and you don't die from a retroperitoneal bleed, for example. And we have newer technologies that, we can get across the lesion now. We have newer technologies that help us to keep the lesion open. So you may have heard of drug-coated balloons. These are balloons that inflate inside, push the plaque to the side, but then deposit a anti-restenotic drug into the tissues at the same time. This is ideal when there are areas that respond well to angioplasty, but we don't need to put a scaffold like a stent inside, and we don't want to leave something behind permanently. This can work very well. But when we do need to put in a scaffold, we have drug-eluting stents, which again have drug coating, as I showed you before, have excellent patency rate, essentially matching bypass at 5 years for the superficial femoral artery. And then here we have, when we deal with calcium, we have something called intravascular lithotripsy, which is a special balloon with high frequency emitters that help to break up calcium and make microfractures so the vessel becomes compliant and we can stretch it with balloons. So I just want to finish with a case here. This is a 54-year-old gentleman with a long-standing history of type 1 diabetes since he was a teenager, who's unfortunately suffered progressive gangrene of his right foot. He already had 2 distal bypasses and both clotted almost immediately. His surgeon told him there are no other options and he was scheduled for an amputation. And you can see why bypass is not going to work. Now, I would guess many of you have not looked at many angiograms, so let me orient you here. So this is a right leg. There's a sheath at the top, and the catheter is aiming down toward the foot, and contrast is being administered. And we can see here that the superficial femoral artery, as soon as this plays again, you'll see it. I'll try to point it out for you. So this is the sheath. This is the superficial femoral artery, which is open. But then all of a sudden, right at the knee joint, everything occludes. Those are collaterals. There's literally no principal vessels here whatsoever. And there's a little bit of reconstitution of a vessel, but really nothing in the foot. So again, if you bypass to one of these tiny branches, predictably the bypass will fail. And this gentleman had 2 bypasses. Well, if the first one doesn't work, the second one certainly isn't going to work. So he went through 2 high-risk surgeries, unfortunately. So, now he's scheduled for amputation, but there are ways to avoid this. So the first thing to do is to inject vasodilators and take a very nice picture of the foot to see if there's any targets we can work with. Even though this is small, this little tiny remnant of the dorsalis pedis is something that I can access. And we can go backwards and reconstruct this. So this is a wire coming in from the foot backwards, as I showed you before. This is a 14 thousandths wire, so it's very small, with a little tiny support catheter. And you can see the calcium in the arteries, and we can kind of see where we're going, and we kind of feel our way through there and advance the catheter and advance the wire. And we eventually get up through the anterior tibial and into the popliteal artery. And then we come from above, and as I was discussing before, coming from above and below improves success dramatically. So we come from above and inflate a balloon into this area, and then we direct our wire towards it to get them into the same space. And then once we get into the same space, we can pass that wire from the foot north, grab it with a snare, and externalize it. So now the wire goes in the foot, through the blockage, and then out through the groin, and then we can work backwards over that wire through the blockage to open it up. So this is just the wire being externalized with a snare. And then this is some balloon angioplasty. And then this patient actually got a drug-eluting stent at the beginning, the origin of the anterior tibial artery, because there was a lot of recoil. And then some drug-coated balloon angioplasty of the popliteal. And then you can see the final results here. So if you follow this down, now we have an open popliteal artery all the way into the anterior tibial, all the way down to the foot. And now you see all these vessels in the foot you did not see before. This is what he came to me looking like pre-procedure. I'm sorry for the gross pictures. I know it's almost dinner time, but this is the reality of what we see. So these things that say number 2 and number 3, those are the surgical bypass incisions. So the trouble is if you have a non-healing wound and you do a bypass and it fails, you now have more non-healing wounds. That is one downside. So you can see these toes sadly are dead. We cannot resurrect these. These are gone. But you can see here only at 1 week we're already getting demarcation here versus having this kind of ascending gangrene going. And we're starting to get some granulation tissue forming here. At 1 month, we're about to cut off those 2 dead toes, but you can see the granulation tissue forming here. This is what it looked like from the side. This was the surgical bypass incision, pre-procedure. This is at 1 week. So again, having a good wound care clinic and having excellent wound care doctors to work with you is really critical. It takes a village to take care of these people, not just one person. It's a lot of people. At 4 weeks, you see the granulation, and we're about to take off those toes. This is 6 weeks later. This is closing. It's not completely closed, but it's closing. At 8 weeks, this is all healed. And this is the 4-foot pre-procedure. This is at 2 months. These toes are gone. There's still some dry gangrene that we're scraping here on the big toe. And at 9 weeks, it's almost completely healed. And by 12 weeks, it was completely healed. So he lost 2 toes. But at 54, he still has a leg and he can still work. It's a huge difference than having an amputation. What if there are no targets in the foot? Like we have nothing we can work with? Well, this is the newer procedure we're doing now. This is called deep venous arterialization, or TADV. So this is a procedure you may have heard called limb flow, and essentially it's kind of a crazy idea, but it seems to work. So if there's no arterial targets, we actually come in and deliberately make a bypass, if you will, or a shunt from the artery into the vein. And we arterialize the vein. So what's happening is the toes and the tissues here are going to get oxygen and nutrients from the back side, if you will, rather than the front side. So that pressurization from the back end changes the biology of the foot. And over the course of several months, the biology changes and the foot gets used to taking the flow from the back side, if you will, and it actually can really work. And there's a study on this showing that it prevents amputation and it can help to heal wounds. So for patients that really have no good targets, rather than an amputation, it's worth trying this first because saving someone's limb is a huge deal. So in summary, identification of PAD is important so that early intervention with medical therapy and risk factor modification can be initiated. So even for those asymptomatic patients, you can make a difference by getting them on the right stuff and getting them under control in terms of their lipids and their blood pressure, et cetera. If they have lifestyle-limiting claudication, they failed conservative measures, including exercise, they should be revascularized because if they don't, humans are lazy and that will not go well for them. And the latest endovascular technologies have really led to outcomes that rival surgery, but without the associated morbidity and mortality. So it's really changed things a lot. And with advanced techniques and a well-developed skill set, almost every case can be treated endovascularly in this day and age with good outcomes. So I will stop there. Thank you very much.